Hello everybody, I'm Denis Godlevsky and we are here with our traditional, it's for the second year in a row, set of interviews from the Union World Lung TB Conference, Lung Disease Conference. And again, we are here with Kristof Perrin, MSF. And Kристоф, my first question to you, well, first of all, thank you for being with us and finding the time. My first question is, since last year when we talked about the novel treatments and the push for the treatment, so what has changed? What was the main achievement you think during this year, if any? Because maybe they were not, because it's not so much time 1 year. But
sure. So hi everyone, and thanks so much Denis for inviting me for a second time. It's always a pleasure. So what has changed? So let me try not to forget something that would have been key. Of course, something I worked very close to, it's the NTB project. This project where there were 2 clinical trials assessing the lamanide-based regimens for drug-resistant tuberculosis. So last year, the outcomes of the first trial, NTB trial, were communicated at the Union, and this year, outcomes of the second trial, NTBQ, for fluoroquinolone-resistant people that have been communicated. And in the meantime, what was interesting to hear is back in June this year, WHO came up with a rapid communication about the delamanide-based regimen, how they could be considered in DRTB care. So there are 2 trials that were considered. One is called Beat Tuberculosis South Africa, and the other one is MTB. And at the end of the day, I won't go too much into details, but the Beat TB South Africa trial regimen plus 2 MTB are recommended by WHO, and they are recommended as the same level of the what was called so far the 9 months regimen, the dacquine-based regimen. So now it means with Beat tuberculosis, it's a 6 months delamanide-based regimen available at the same level of the 9 months, plus a 9 months delamanide-based regimen. Also, the interest of those regimens is actually it's opened up more options for patients, because there is a tension in TB between putting everybody in the same role, same regimen, Bipal-M, and then or being a lot more adapt the regimen to the patient profile, the type of resistance, intolerances he or she has, etc. So now more options. Also, the good thing is that since pretramanide cannot be administered in children so far, because there's no data for children under 15, if I'm correct, the delamanide-based regimen are recommended, so that's the good news. Those regimens are also recommended for pregnant people, so that's also good news. So in a way, with that, it has opened up the options of older regimen, shorter regimen, good efficacy, and good safety profile. So that to me was a big thing that happened this year already.
yes, can I elaborate on that?
Sure.
Because so basically, another consequence of this would be that we now have a proof, like a bigger proof, for a wider use of delamanide.
Yes.
So it means there is a basis to increase the volumes of delamanide production.
Yes.
Which brings us to the issue of pricing,
Yes.
which you were actually talking yesterday about first time ever in the history of this conference. At the plenary, you were talking about access, and in particular, you were talking delamanide. So maybe you can share with those who are not able to attend. What did you say?
Sure. So during this session, I tried to give an overview of successes and challenges in access to TB medicine in the past 25 years. So a lot of successes, like in the RTB, clearly now all of our regimens, shorter, a lot cheaper, $8,000 for 20 months regimens with injectables in 2011, and 15 years later, we are with a Bipal-M costing less than 500, 6 months regimen costing less than $500. So such a big change actually. and of course all over regional BPLM. So that's a big change. And within this perspective, of course, not everything is perfect and evenly at the moment. So for delamanid, it's an interesting compound. Now WHO is recommending delamanid-based regimen. The issue is the price of delamanid went from $2,500 for a 6 months course in 2015 to $800 for 6 month course just recently in September. So of course that's quite a price decrease, 3 times less, but still with $800 for 6 months course, it makes delamanid pretty unaffordable in many contexts, and it leads to delamanid-based regimen costing 3 times more compared to BPLM. That's the issue. And then probably with the audience, since you might have some people from Eastern European countries and Central Asia, in those contexts, GDF, so the Global Drug Facility, which is able to supply Otsuka's delamanid and Viatris delamanid. Otsuka's delamanid, $1,200 for 6 month course now. Viatris delamanid, $800 for 6 months course. And unfortunately, in the list that has been shared by the GDF online, with the list of countries that can buy at Viatris, at Viatris only, Otsuka only, and or Otsuka and Viatris and all, the countries that are blocked with Otsuka are the vast majority of Eastern European and Central Asian countries, except Armenia, which is able to purchase directly at GDF Viatris product, delamanid, and the Russian Federation, which is, never mind, purchasing directly at AFA.
Yeah, it's a different story.
It's a different story. So just to say, those countries are going to be even more affected by this high cost of delamanid, meaning that even the cost I mentioned for big tuberculosis, South Africa, NTD, in those contexts, it will not be only 1,400, so 3 times BPLM cost. It will be, you have to add 800. So in those countries, it means those regimens are going to cost $2,200, which is a real expense.
What are the key recommendations that you are suggesting to try to reduce the price?
So
Otsuka, Viatris, or both?
So Otsuka told clearly to many actors in the civil society they will not move the price below than 1,200
for their own product.
For their own product. Viatris is working on an even cheaper version of delamanid, below 800, but it might take for them to do so 1 more year. And they're not mentioning any target price, but it will lead to a reduction of price. So in 1 year time. And in parallel, what's coming up, it's generic competition happening because Viatris has signed a license with Otsuka, but a license which is very much leaving no space to Viatris to many initiatives. So in a way, Viatris is almost a subcontractor to Otsuka. They will hear me saying so, but they have been very stuck in how they could approach the delamanid production. But the generic manufacturer will have no link with Otsuka at all. The primary patent held by Otsuka on delamanid expired last year in October 2023. Otsuka is still holding a series of secondary patents, including one on the formulation, which could be tricky to generic manufacturers till July 2026. But from what we hear, 2 generic manufacturers are working on a formulation which will not be blocked by this patent. So that's quite a good news. And meaning we're in November 2024, we might see a generic delamanid, so completely free from Otsuka, completely different from Viatris, maybe coming up to market at the end of next year, so Q4 2025 or Q1 2026. So that might be where we are at the moment.
I have another question related on that. We have faced once a situation in Russia before lopinavir ritonavir was freed from all the patents by Abbott because of the COVID. You remember they also said that they will give up on everything, but the patent was already expiring, so they really didn't care. But one of the generic companies there developed their own formulation to go around the patent, and then what they did, they patented this go-around way inside Russia.
Gosh.
So do you think it is something that might happen in this case, that the generics might want to patent this approach, and what do you think of this behavior? If you ever have you ever seen anything like that in other maybe diseases or in other cases? No?
At least, how to say, Indian generic manufacturers, I never saw them doing so. I'm not.
They won't be able because of the 3D section in their own
You're
country.
right, exactly,
Yeah.
exactly. You're absolutely right. So, just talking while I'm thinking, I can understand why probably in the Russian Federation they've done so. For Delamanid, I'm afraid nobody will go down that path just because of the volume.
Yeah.
If this did not happen for bedaquiline, then I don't see that happening in the Russian Federation for Delamanid.
Okay, good. Getting back to our first question, because I interrupted you. Other important achievements in the year, what would you like to highlight?
Gosh, what it is. Sorry, it might be completely bits and pieces.
No,
because I did not
no
anticipate the
worries.
answer. So, one thing that comes to my mind is now we've got a dispersible tablet for children for rifampicin, 150 milligrams. So that's great news. It means children can be treated for TB prevention with 3HP, 1HP regimen. It works. We have the isoniazid dispersible tablet, rifampicin dispersible tablet, so that's fantastic news. So it's an additional option compared to 3RH, etc. and isoniazid 6 months that we are now, so that's fantastic news.
Yeah.
So that was very good news this year. Trying to move backwards with the months, so August MTB, BTB, June it was rifampicin dispersible tablet 150 milligram. What else was good news this year? There were so many bad news that it's terrible that probably they dropped down the good news. What was another good news? TPT, yeah. Also, the 4 months regimen, HPMZ, for drug-sensitive TB. The first generic manufacturer submitted its product dossier to the expert review panel of the Global Fund and the WHO for qualification for a fixed dose combination, both for HPMZ and HPM. So it means probably what?
Yeah, unpack HPMZ for those who are not familiar with the terminology.
Sorry. So till now, till recently, because I think it was 2022 if I'm correct, the main recommendation to treat drug-sensible TB in adults and children was a combination of rifampicin, isoniazid, pyrazinamide, and ethambutol. And that's for the past 20 years, even more.
Yeah, that's what I got as my treatment. Yeah,
the very robust standard regimen. And there have been evidence now for a shorter regimen of 4 months instead of 6, combining isoniazid, rifampicin, moxifloxacin, and pyrazinamide. And if I'm correct, at the moment it's recommended only for person of more than 15 years old. It's for adults only for now. And so it's a shorter regimen. So interesting because people have to take less medicine compared to what it happened to you during 6 months. So that's a less burden on the patient, less burden on the healthcare workers. The only thing, combining those medicines, especially rifampicin, makes the regimen a bit more expensive compared to the standard one. At the moment, it's 3 times more costly. $50 for 6-month treatment with RHZD, the old one, and it's about $150 for the new one, HPMZ, even though it's shorter. The only thing, the argument can be also for national TB programs to move ahead, that they have less expenses, 2 months of expenses less in nutrition support, in social support, so that could compensate. And the good news, I was just talking with a generic manufacturer who could come up, they think, with this regimen at $130 instead of $150, not a big difference, but already something. And they were thinking as soon as the volume rises up, they could get easily around 100.
Okay, that's also good news.
So that's, yeah.
I also recall Macleod's pre-qualified their products this year, right? For Pretomanid, they got the pre-qualification also. That's
exactly.
Good news, more competition.
And they got pre-qualification for bedaquiline also, just 2 weeks ago. So more competition. Great good news. Just now, in a meeting I was just an hour ago. Some of the people listening to this video, viewing it, might remember last year, in September 2023, Johnson & Johnson committing for non-enforcement of their secondary patent in 134 countries. Non-enforcement means that this secondary patent is not implemented and will not block access to generic bedaquiline, which was a major advocacy effort done last year, and I think we talked about it in the video last year. And there was fear among the civil society community that still there would be challenges for generic manufacturers to register bedaquiline. And I've got the fantastic news that at least one of these generic producers of bedaquiline managed to register in South Africa, in India, in Indonesia, in Thailand, in Vietnam. They are filing in Brazil, so it means the fee we had was completely theoretical. It's what Johnson & Johnson committed not to do. They are not doing it. So yes,
good
and
news.
Meaning advocacy can lead to good results. And this generic company was just so happy about what we did, because of course it's more business for them, and more important than more business for them is more affordable quality assured bedaquiline available for more people in the world.
Yeah, that's the main thing. Okay, last question, not sure it's going to be easy. We talked with you and some other people last year about the future of the Access campaign, and many of the viewers signed the letter to support Access campaign and make MSF sure that it continues. So if you can, any news on what's going on, any updates?
Sure, no, thanks for the question, Dennis. And first of all, massive thanks to all the people who signed this joint letter to support what could be the future of the Access campaign. I think it's more than 600 civil society organizations across the world. I mean, for us at Access campaign, it was honestly, it was such an emotion, and even now I'm getting a bit emotional. So I'll try to control myself. And so thank you so much, because it was already great for us, since we have had the luxury and the privilege to work with all of us during all these years and all what we could achieve. So that's one thing. It demonstrated within MSF that for those not really sure about the added value of the Access campaign within MSF, that it was rooted with civil society organizations across the world. We had from Kazakhstan, Kyrgyzstan, Latin America, Africa, you name them, and across every single continent, people came up with support, which was very, very touching. Unfortunately, despite this magnificent letter, the management of MSF has not changed their mind, and the Access campaign will stop functioning at the end of the year. So a new structure dedicated to access, that's what they say, is being created, and it's difficult for me to understand exactly what is the strategy, what is going to be their work plan. So at the moment, there's a lot of uncertainty. There's a lot of talk, a lot of promises, but concretely now, it's hard for me to say how MSF is going to keep being committed on access. So in the way that you knew Access campaign and we've been working at Access campaign, so that's a question mark. Then MSF is a big house, and sometimes people feel that big things are only happening in the big house of MSF, let's say the major building, but MSF is so big that often interesting things are happening in small huts around, and it might be that some of the advocacy work that some of you saw going through the Access campaign might be coming up with an MSF hat, but from smaller huts, and still to try to be concrete, pragmatic, collaborative with whoever is doing advocacy in the world. So at the moment, honestly, it's a bit blurred, but some initiatives will definitely carry on around advocacy and access.
Yeah, I'm also getting emotional when I hear this. Like, untangling the web of antiretrovirals was probably one of the first documents I read, which inspired me to start untangling the world of pricing in Eastern Europe and Central Asia, which led to the whole, area of work we're doing now. And I really hope that, whatever will be there will be at least 50% as useful as the Access campaign was. Yeah.
And I talked a lot, so perhaps I need to limit my words now, but the last thing I wanted to say, interestingly, you mentioned untangling the web, this fantastic report to bring transparency for the cost, the price of antiretrovirals for HIV. Similar things happen for hepatitis C, under the microscope for TB medicines. And what I started to hear, some people would like to repeat the same methodology outside MSF. So in a way, of course, it's, and I'm getting
Goosebumps?
Goosebumps, exactly, thanks saying so. But some of the initiatives we had at the Access campaign might be strong enough so that they carry on having their own life outside MSF, which is fantastic. There was no copyright on anything we did at Access campaign. So actually, at least for the TB, just here at this conference, I've had already conversation with 2 people who would like to work next year on the RTP drugs under the microscope, thinking especially ahead about the new compounds coming up, and there will be a need on transparency on how much they're going to be priced.
Yeah, I think there is no doubt that the strategic impact of the whole work is you cannot undo it, and it will continue to impact the whole sector because so many great professionals will be around. And I really thank you for all the work that you are doing, and I'm sure you will continue doing in no matter which capacity. And I'm sure this is not the last our talk. I'm sure we will talk in a year, no matter in which capacity you will be attending the conference. But I wish that everything is okay with you and the rest of the team.
Thanks so much, Dennis. No, thanks so much, and I wish next year, apparently in Copenhagen or Dublin or Lille.
I haven't heard yet, so you are now announcing it.
Yeah, it seems like the top player is Copenhagen, then Dublin and Lille at the north of France are the cities under consideration for the next year.
Okay, so we'll see.
We'll see.
Thank you so much for your time.
Thanks.
I really appreciate you coming, and good luck.